To make sure we hit every critical detail, we're dividing this up into 5 key areas today: esophageal diverticula, hiatal hernias, perforations, rings and infections, and we'll wrap it all up with motility disorders.
Starting off with Section 1, esophageal diverticula, which are essentially structural outpouchings of the esophagus.
Now, here's a concept you absolutely have to nail down: the difference between a true and a false diverticulum. The parabronchial diverticulum, right there in the middle third, is the only true diverticulum because it actually pulls all the layers of the esophageal wall outward. This happens via traction. Think of it like a tent being pulled from the outside by inflamed, scarring lymph nodes, usually from things like TB or histoplasmosis. False diverticula, on the other hand, like Zenker's in the upper third or the epiphrenic down in the lower third, are pulsion types. That means only the mucosa is getting pushed out, kind of like an inner tube bulging through a weak tire, strictly due to increased internal pressure.
Zooming in on that upper third, Zenker's diverticulum uniquely herniates straight through a very specific anatomical weak spot. It's called Killian's dehiscence. What happens is you get uncoordinated muscle contractions, pressure builds way up, and it forces the mucosa right out through this potential space tucked between the oblique and transverse muscle fibers.
So what does this actually look like in practice? Picture this. A patient comes in complaining of regurgitating undigested food, and frankly, they have severe halitosis, bad breath. That's because food is literally just sitting and stagnating in that pouch. If you see that, think Zenker's immediately. Now, the most common and dangerous complication here is aspiration pneumonitis. And when it comes to the surgical fix, it's absolutely crucial to remember that you can't just cut out the pouch. You must also perform a cricopharyngeal myotomy. If you don't cut that muscle to relieve the underlying pressure, the whole thing is just going to come back.
Moving right along to Section 2, hiatal hernias, specifically comparing sliding versus rolling types. It is absolutely critical you don't confuse these two because managing them is wildly different. A type 1 or sliding hernia is by far your most common diaphragmatic hernia. The GE junction just slides right up into the thorax, which, as you'd guess, predisposes the patient to GERD. If it's asymptomatic, honestly, we just observe it. But look at type 2, the rolling hernia. Here, the stomach rolls up into the chest alongside a perfectly normal GE junction. This one is an absolute surgical emergency. Why? Because that herniated stomach can undergo volvulus. It can twist on itself, leading to necrosis. Type 2 always requires surgery, no exceptions.
Oh, and while we're on the topic of rolling hernia, you'll want to keep this specific buzzword locked in your brain: Cameron's ulcers. These are longitudinal ulcers that form right at the mechanical pinch point at the base of that herniated stomach. If you see Cameron's ulcers pop up on an exam or in a chart, you are absolutely dealing with a type 2 hiatal hernia.
All right, Section 3, esophageal perforations. We're looking at iatrogenic versus spontaneous causes here.
Now, while iatrogenic perforations from endoscopies are the most common overall, it's the spontaneous ones that will really test your diagnostic chops in an emergency. You do not want to mix these two up, especially in an alcoholic patient who just had a severe bout of vomiting. Boerhaave syndrome is catastrophic. It's a spontaneous, full-thickness rupture of the lower third of the esophagus, and the patient is going to be highly unstable. On the flip side, a Mallory-Weiss tear is strictly a mucosal tear. It causes upper GI hemorrhage, hematemesis, but it's often completely self-limiting. That's your defining line: full-thickness rupture versus a superficial mucosal tear.
If you suspect you're dealing with Boerhaave, there are a few classic buzzwords you need to spot instantly. First is Mackler's triad: chest pain, retching, and subcutaneous emphysema. Second, if you listen over the heart and hear Hammond's crunch, which literally sounds like someone walking on fresh, crunchy snow, that tells you there's air in the mediastinum. Anatomically, the tear almost always happens on the left posterolateral wall. And to safely diagnose this in an unstable patient, you absolutely have to use a water-soluble contrast like iohexol. Do not use regular barium here.
So what happens if a Boerhaave patient presents late? Well, sepsis is probably already setting in, meaning they aren't going to survive a massive, prolonged operation. In emergency trauma surgery, we have a saying: a living problem is better than a dead solution. So you do a drastic 4-step damage control surgery. 1, you stable off and cut out the perforation. 2, bring the proximal end of the esophagus out the neck, an esophagostomy, so saliva drains out. 3, create a gastrostomy feeding tube for nutrition. And 4, you just wait. Let them heal up and you go back in 10 to 12 weeks later to reconnect everything. It's intense, but it absolutely saves lives.
Shifting gears to Section 4, rings and infections.
specifically what we see on mucosal imaging.
This whole section is about matching a visual cue to a specific pathology. Check this out. When a barium swallow shows this corrugated, stacked-up appearance of horizontal lines, you're looking at a feline esophagus. It literally looks like tiger stripes. Now, if you spot this in the lower third, it's classically driven by GERD. But if it's sitting up in the upper third, especially in a pediatric patient, your brain should immediately jump to eosinophilic esophagitis.
When it comes to infections, it's basically rapid-fire word association. You need to connect the endoscopic visual directly to the bug. Got a shaggy appearance with worm-like ulcers? That's Candida. Seeing large serpiginous geographical ulcers, maybe in a post-transplant patient, you're dealing with CMV. And if you see small ulcers with distinctly raised margins, that points directly to a herpes infection. Lock those 3 visual associations in, and you're golden.
And finally, Section 5, Motility Disorders, focusing on the Chicago 3.0 classification. To really understand these disorders, we rely on high-resolution manometry. It's the gold standard. Look at how beautifully this table breaks down the Chicago 3.0 criteria for achalasia. Notice that across all 3 types, the integrated relaxation pressure, or IRP, is elevated. That's the baseline proof that the lower sphincter is failing to relax. What actually separates the 3 types is the distal contractile index, or DCI. Type 1 is your classic failed peristalsis with a super low DCI. Type 2 is characterized by panesophageal pressurization. And type 3, that's the spastic variant, featuring totally premature contractions and a massively elevated DCI.
On a clinical level, achalasia literally translates to failure to relax. This happens because the patient has lost their inhibitory ganglion cells. They're going to present with a highly testable classic triad, dysphagia, which counterintuitively is often worse with liquids than solids at first, along with regurgitation and weight loss. On a barium swallow, you get that iconic bird's beak sign. It's a very smooth, gradual tapering down to the tight sphincter, which looks completely different from the abrupt, ragged narrowing you'd see with an esophageal cancer.
The modern fix for this is absolutely brilliant. It's an alternative to the traditional laparoscopic Heller's myotomy, called POEM, per-oral endoscopic myotomy. Using just an endoscope, surgeons literally tunnel down right into the wall of the esophagus, snip the tight circular muscle from the inside out, and seal it back up. It leaves 0 abdominal scars, and it's remarkably effective, especially for folks with type 1 and type 2 achalasia.
To wrap up the motility side, let's contrast achalasia with a couple of other big hitters. Take distal esophageal spasm. Here, the sphincter relaxes normally, but uncoordinated spasms in the esophageal body cause severe angina-like chest pain. On barium, it gives this wild, classic corkscrew appearance. Compare that to nutcracker esophagus, which, believe it or not, is actually the most common motility disorder overall. The contractions are coordinated, but they are ridiculously powerful. In its most extreme form, aptly named the jackhammer esophagus, it generates massive localized pressures, with a DCI shooting over 8,000.
Well, we've covered a tremendous amount of ground really quickly today, from anatomical outpouchings all the way down to neuromuscular chaos. As you go back and review these concepts, I want you to ask yourself, at what point does a simple structural flaw cross the line and become a catastrophic functional failure? Understanding that delicate, complex balance between anatomy and function is the true key to mastering the esophagus. Keep that question bouncing around in your head, and you're going to conquer these topics with absolute ease.